Okay. Buenas tardes, señores y señoras. Welcome to our primer día Latino. I cannot say concientización, too hard. But this is a great day for us. This has been in the planning for quite a while. As many of you know, I guess I should introduce myself. I don't know a lot of you. I'm David Celentano. I'm a professor and chairman of the Department of Epidemiology at Hopkins, but I also run the prevention core of the Johns Hopkins Center for AIDS Research. And we are coordinating this program today with the CFAR's Baltimore HIV Collaboratory and the Center for Excellence for Latino Health at the Bayview campus. And our purpose is to try and engage people in HIV research, to work with the community, and to do outreach. So we are holding this event today in recognition of National Latino AIDS Awareness Day, which is actually on October 15th. But this is the closest day for us. So we're pleased that you all are here. At 1 o'clock or 1:15, please join us downstairs in the gallery for lunch, and you'll have a chance to talk with our speakers. Thanks to Jordan White and Tamara Fliss for organizing this today. We also want to acknowledge Ann Dennis, who will be our principal speaker, who actually is a Hopkins graduate, undergraduate from Homewood. And certainly we want to thank Kathleen Page for moderating today's panel discussion. So let me introduce Kathleen to you. For those of you who don't know Dr. Page, she's an assistant professor of medicine at Hopkins. She's director of the STD, HIV, TB clinical services for the Baltimore City Health Department. It's a program, we've had somebody in charge of this for at least the last 30 years that I'm aware of. She received the 2013 Diversity Award, Recognition Award for her really diligent work in improving access and quality of culturally competent healthcare services for Latino immigrants in Baltimore. And she was instrumental in the establishment of the Center for Excellence for Latino Health at Bayview, Centro Sol. So, Kathleen.
Hi, thank you for the CFAR for hosting this. And it is really my delight and privilege to introduce Ann Dennis to you guys. I feel like I've known her by authorship for some time. Ann is at University of North Carolina, and where she completed her infectious disease fellowship. And a couple of years ago, she published some work which I felt was very relevant to what I was seeing here in Baltimore. And I've actually used that work in many of my grants to justify the work that I do. And so I am thrilled to have someone outside of Hopkins share their experience with Latino immigrants and HIV, and hopefully we'll be able to draw some similarities with what we see here and move forward. So thanks, Ann, for coming.
So thank you for that kind introduction. I am really excited to be here today and to meet everybody that I spoke with today. I think we are going to draw some parallels from what you have been seeing here in Baltimore. So I'm going to go ahead and get started. I've been charged with 20 minutes, so I'm going to run through these slides fairly quickly. But I would like to start out first with a global perspective. So in general, the Latin American epidemic has been stable, primarily with a low-level generalized epidemic and concentrated epidemic among high-risk individuals, so MSM and female sex workers predominantly. So this map here shows the general HIV prevalence among all races by country. Can you hear? Is that better? Okay, sorry about that. Thank you. So again, this is a map here showing the HIV prevalence by country. I just wanted to point out, Mexico has a little bit lower of HIV prevalence than the US, but the epidemic may be closely tied to the US through migration. So in the US, Latinos are a rapidly growing ethnic minority group and the largest ethnic minority group in the US, with origins in over 20 different countries in Latin America. Thus, this is a heterogeneous group composed of subgroups that may vary from one another culturally. Therefore, we can't assume that the character of the epidemic is the same within all these subgroups. So while the US in general has experienced a significant Latino population growth, southeastern states have seen the largest percentage increases in Latino growth compared to other regions. So the southern region, in general, experienced over 100% or doubling of the population just over the past 10 years. So as you can see here from this map, Maryland had a similar growth rate compared to North Carolina. So the demographics of North Carolina have changed significantly over the past 30 years. Most of the population increase occurred between 1980 and 2000. So we experienced about a 400% increase during that time period. However, some metropolitan areas actually experienced much higher increase, what we term hypergrowth, where the population increased more than 1,000%. So in 1980, as you can see here in this map above here, there were very few counties that were more than 5% Latino. However, by 2000, as you can see, there were several counties spread throughout the state that were more than 15% Latino. So in general, population growth did increase in the South among all sort of racial and ethnic groups, but was again much higher for Latinos. So this chart here just shows the growth rates in the South compared to traditional settlement areas. And when I talk about traditional areas of settlement, I'm talking about places that have long seen established communities such as New York, California, Chicago. So in the South, the economic growth that occurred predominantly in manufacturing, construction, drove the population growth in the Southeast. So compared to traditional settlement states, Latinos in the South were a little bit different. They're more likely to be foreign-born, more were coming from Mexico. A higher portion were men, often unaccompanied from female partners, and many were more recent arrivals, having arrived after 1995. And a significant proportion also are estimated to lack legal status. So what about HIV? So in North Carolina, the new HIV diagnoses in Latinos had increased significantly, represented about 1% of new diagnoses in 1999 to about 8% in 2008. So this is largely reflecting the growing Latino population in the region. So there has been a steady but fortunately low-level increase in the number of cases since 2004. However, the rate of new diagnoses is nearly 3 times greater than that of whites, following national trends. Latinos as a subgroup are very disproportionately affected by HIV. The process of migration itself may put Latinos at higher risk for HIV. So the process of migration can lead to the loss of social and sexual networks. This may be more pronounced in the Southeast because as a new settlement area, these social networks may not be as well established, may lead to isolation. Some studies with Mexican migrants have found that some migrants may be more likely to engage in riskier behaviors following migration, such as having multiple sexual partners and an increase in illicit drug use. So migrants are also can be a marginalized population with significant barriers to accessing preventative services. And there's also a link between male migration to the US and HIV risk in Mexico. So a significant number of cases, nearly a third of cases of AIDS cases reported in Mexico are now reported in southern states, which historically send the largest number of migrants to the US. So I'd like to just give a quick overview of some of the recent and current UNC projects. The ones that I've highlighted here, the ones that I'm just going to be talking a little bit more in the presentation. The first thing that we looked at is our analysis of our UNC CFAR cohort, which is this prospective observational cohort of our patients in clinical care at UNC. So we follow over 2,000 patients who are actively in care. And we looked at the cohort specifically to evaluate late presentation to HIV care. And then next, I'm just going to briefly tell you a little bit about demographic and migration survey that we conducted at 3 clinics in North Carolina is really to give you more context with our data on late presentation. And I would also like to mention some of the other work that's done in North Carolina with our research group, namely with Drs. Claire Barrington and Lisa Heito-Weidman. Claire Barrington, I believe, is another Hopkins alum. She's in the School of Public Health. And they did some in-depth qualitative work looking at life histories of HIV-infected Mexican-born men. Studies that we have in progress or upcoming, I'm going to briefly talk about our molecular epidemiology work. Lisa Heito and Claire Barrington have also conducted, they're more onto the intervention side. They have conducted a mixed methods pilot intervention using new ways of social recruitment. So they use respondent-driven sampling to help promote HIV testing. And then UNC was recently awarded a HRSA SPINS Latino Initiative grant to promote early testing, linkage to care, and retention among Latino, transgender, and MSM. And so we're really excited about that initiative. Okay. So in our analysis of our CFAR observational cohort, we evaluated Blacks, whites, and Latinos who entered HIV care for the very first time over an 11-year time period. So about 11% of the population was Latino. So I just want to point out several differences. First, Latinos were significantly younger than the other groups. There was a high proportion of men. Most reported being heterosexual, about 60%. For the women, most were diagnosed with HIV during pregnancy, nearly 40%. And Latinos were significantly more likely to present with lower CD4 counts. Latinos were also more likely to reside in rural areas. I just wanted to show you this map just to give you an idea of our clinic catchment area. So you can see it's kind of hard to see, we're right here kind of in the middle, but we see patients all across the state from urban areas to rural areas. So quite a diversity and presents many challenges for prevention. So Latinos, as I already mentioned, were significantly more likely to present to care with advanced HIV disease compared to all the other groups. So this figure here shows the percentage of patients who came into care with CD4 counts less than 350. So that's a number where antiretroviral therapy is clearly indicated. So Latinos here are shown in green, and as you can see, over the 3 time periods we looked at, over 70% were entering care already requiring antiretrovirals, and this really did not change over the time period as it did with the other groups. So Latinos were also more likely to enter care with an AIDS-defining event and accounted for the majority of specific opportunistic infections. So again, Latinos here are shown in green and accounted for most cases of active TB, histoplasmosis, and toxoplasmosis. So these are infections that generally reactivate after latent periods and likely are acquired elsewhere, such as histoplasmosis, because it's really not endemic in North Carolina. So we suspected a large proportion of our patients are immigrants. However, we did not have migration data that was routinely collected in our CFAR cohorts. Although our cohort and our consent process, it is available in Spanish. So therefore, we collected additional data from patients that are in care at 3 clinics in North Carolina. I just wanted to show you the location of these clinics. Here's UNC kind of in the middle. And just to give you an idea, all these surrounding counties are pretty high proportion of Latino patients. So with this study, we conducted face-to-face structured interviews with 127 patients. So the surveys captured risk behaviors, acculturation, migration history. So I briefly just want to show you some of the results just to give you more context to the late presentation to care data. So most of the patients we interviewed are men. We felt that our sample was actually very well representative of our clinic population. About half the men reported having sex with men in the past. Another 40% reported heterosexual risk. You know, of note, we have pretty little active IV drug use in North Carolina and what we're seeing among this group. So of those interviewed, 82, so the majority were immigrants. Most are monolingual Spanish speakers with pretty low US acculturation. The majority of immigrants are diagnosed in the US. Most are actually diagnosed in North Carolina. Nearly 2/3, as you can see from this chart over here, are actually diagnosed within 10 years of immigration. But compared to US-born Latinos, immigrants were different in a couple of ways. Again, they had lower CD4 counts. So as suspected in our cohort analysis, we felt a lot of what was driving the low CD4 counts was actually the immigration status. Immigrants were also, the men were less likely to report sex with other men. But also, the men were more likely to report paying for sex in contrast to the US-born Latino men. However, sample size was a little bit limited. This just didn't reach statistical significance, but trended. So this map shows the states and countries of origin for the participants. Most were from southern Mexican states, which are historically migrant-sending regions to the southeastern US. And other states with the highest number of participants included Honduras, Guatemala, and El Salvador. So HIV treatment outcomes are generally good despite late presentation to care. So of our participants in our clinics, most were on antiretrovirals, had suppressed viral loads. And I just wanted to point out another analysis that I thought was pretty interesting that was done in Houston, which did a comparison looking at not only all the racial and ethnic groups, but looked at Latinos that were immigrants that were undocumented versus documented, and showed that the undocumented immigrants did enter care with much lower CD4 counts. However, they had excellent retention rates and similar rates of viral suppression, so they did very well. So next, I'd like to shift gears and talk about our molecular epidemiology work. So HIV transmission among Latinos in North Carolina is really not really very well understood from a population level. So we have an ongoing project to reconstruct transmission networks using HIV nucleotide sequences to help us further understand the extent that Latinos may be integrated into our local epidemic. So population-based sequence data can help characterize the structure of epidemics. So this is a new approach to epidemiology. So paired with traditional epidemiologic data, this may provide insight into groups responsible for ongoing transmission. So poll sequences, so derived from HIV resistance testing. And resistance testing is now part of general indicated care for everybody entering or being diagnosed with HIV. So nearly everyone coming into care these days will have an HIV genotype. And this segment of the genome does have sufficient variability to allow for phylogenetic reconstruction. So using these nucleotide sequences, we could reconstruct the evolutionary history of the virus, or the phylogenetics. So how the sequences group together based on genetic similarity and inference of common ancestors. So here's just, basic schematic here of a phylogeny. This is one, cluster. So these, each tip out here represents an individual sequence from an individual patient. The node furthest out here represents the common ancestor. So this is what we call a transmission cluster, which is a clade, phylogenetic clade, where representing people who have very similar viruses that they shared HIV transmission. So we initially sought to characterize transmission networks among all groups in North Carolina using sequences available in our CFAR cohort. So here I just wanted to give you a brief overview of this, sort of our initial analyses. And we analyzed approximately about 1,700 individuals. So first, we reconstruct the phylogenies, from the sequences extracted from genotypes, using computational methods. We then identified clades or clusters. In this case, we were looking at larger networks, so 3 or more patients that represent ongoing transmission. So overall, we found about 20% of our sample to be members of these larger clusters. So just down here, this just gives an idea of the different sizes of the networks. We then integrated this data with our demographic and risk behavior data to identify traits associated with transmission. So I'm not going to go into all of the other outcomes in this study. I just wanted to highlight what we found with our ethnicity data. We found that few Latinos were actually represented in these larger clusters. They were more likely to be, there were few that were sort of interspersed into the big clusters, and more were just kind of single and out there and non-clustered. So I want to give you just an example of a large transmission cluster involving Latino patients. As you see here, the Latino patients are here in green. The majority of the patients here are African American. All of these patients reported heterosexual risk. And as you can see, it was more women than men. Incidentally, most of these patients had resided in one kind of smaller town in North Carolina. Of these 3 Latino patients, all 3 were immigrants from Mexico, and they all had reported living in North Carolina about 10 years prior to diagnosis. So this is an example of a transmission cluster showing Latinos being integrated into the local epidemic. So we're now working on integrating our updated phylogenetic data with migration data to better characterize any cluster that includes at least one Latino. And here to look at some of the smaller clusters, looking at pairs of 2 sequences together, as well as the larger clusters. So our data set here includes 177 Latinos, most of whom participated in the interviews that I described earlier. And we also integrated into the general population of about 1,500 sequences from non-Latinos. And again, here just gives you the distribution. Most of the patients providing sequences are immigrants from Mexico. So in this analysis, we found 33 clusters involving at least one Latino sequence, which included about 31% of the patients from our study population. So most were in pairs. This median cluster size was 2. We found that both US-born Latinos and immigrants were both kind of equally likely to be members of clusters. But the immigrants were actually more likely to be in clusters with another Latino, indicating some within ethnicity transmission. So smaller clusters, those in pairs, also looked a little bit different from some of the demographic features compared to the clusters that were larger. So the smaller clusters here, just involving 2 patients, tended to have more patients reporting heterosexual risk, and indeed most of them were male-female partners. However, the clusters that were larger that Latinos were members of tended to be more likely to be MSM. So next, we assessed factors associated with immigrants being members of these clusters. So we found that immigrants in clusters were more likely to be younger at the time of diagnosis, to have originated in Mexico, and have resided in the US for over 10 years. Also, more MSM were identified, as I mentioned before, in these clusters. But what about immigrants not in local clusters? So most immigrants we found, in our sample were not found in these local clusters. What does this mean? Possibly HIV is contracted outside of our region, other states. Perhaps our sampling density is not sufficient to really capture the networks. I just wanted to show you a couple examples, some other projects that we're working on with our collaborators from Mexico. We're looking at integrating our data sets. With sufficient sampling density, perhaps, other clusters can be uncovered in any transnational clustering. So on the left, what looks like, this big starburst here is actually just a big phylogenetic tree with over 3,000 samples, including thousands from our collaborators in Mexico. And from our data set, kind of in red, but you can't see them because we really only have 177. But if we zoom into the cluster that includes one of the sequences from one of our patients, this is a cluster of 9 patients, actually, with most of the sampling was done in Mexico City. These are all MSM, and then one of the samples was done in North Carolina. So this is, just gives you an example of some connections between the regions. Okay, well, there's several things to conclude today in this, brief overview. So, first, Latinos in the Southeast, may be affected by HIV in differently than other regions of the U.S., being a new Latino settlement area. Presentation to care, late to care remains unfortunately common. From our data, it looks like most of that is from testing late rather than a failure to link and retain in care. In North Carolina, we have a high proportion of immigrants and that are identifying as heterosexual. Most are diagnosed within 10 years of arrival. Using kind of new techniques, maybe phylogenetic analyses in conjunction with traditional epidemiologic data, we offer some unique insights to help us understand transmission patterns. But what we need is really innovative ways to reach Latino immigrants for early HIV testing, especially shortly after migration was a particularly vulnerable period, and particularly regardless of risk stratification. So these are definitely needed. And, again, culturally appropriate prevention, linkage to care, and treatment, of course, is necessary. And this includes transnational approaches. So I'd just like to conclude with a few acknowledgements. Of course, all this work is a collaboration, and there's many people I'm probably not thinking. I just wanted to call out a few people who have been very supportive along the way. Joe Iran has been my primary mentor since I was a fellow at UNC and remains that way. Bill Miller, an epidemiologist in our division, and as well as Mike Cohen. I'd also like to mention Claire Barrington and Lisa Heito-Weidman, that we work together on some of these initiatives. And then I just want to mention Eric Valera, who is a research assistant on our projects and conducted a lot of our patient interviews. He has now left UNC and is a program director of Latinos in the Deep South initiative on the Latino Commission on AIDS. Okay, and I'm happy to take any, I think we're going to move on to the panel, and then we can take questions.
Thank you so much, Anne, for that presentation. And I really think that for those of you, and I also want to thank the members of the community who have come here, but for those of you at Hopkins or in the community who are working with Latinos with HIV, I think probably a lot of what Anne said resonated. I know for sure that in our clinics we're seeing very similar and concerning late presentations, and it's something that we've been trying to work very hard to address. So without further ado, what I'd like to ask the panelists to do is to introduce yourselves briefly and tell us a little bit about what you do and how you're involved in the Latino HIV work in Baltimore. So do you want to start, Suzanne?
Sure. I'm Suzanne Dolwick Grieb, and I'm a postdoc or research fellow in the School of Medicine Center for Child and Community Health Research. And I've been in Baltimore for 3 years, and I came following completing my PhD in medical anthropology, looking at transnationalism and HIV risk among a migrant group from Honduras. And so when I came to Hopkins, I began working with Dr. Page and Alejandra and the Latino outreach team to do some of the formative work to try to further prevention efforts among Latino immigrants here in Baltimore. And the specifics, I guess we can discuss.
I'm Alejandra Flores-Miller, and I am the leader of the Latino outreach team at Baltimore City Health Department. We do HIV testing in the Latino community and linkage to care. I started working with Dr. Page 5 years ago in this project.
Good afternoon. My name is Alfredo Santiago. I'm a social worker at Baltimore Medical Systems. I work in the behavioral health unit, but specifically I'm here because I have worked in the past with the outreach team and I'm currently a facilitator for the Latino HIV support group that meets at Baltimore City Health Department.
Great, thank you very much. So I will start off with a few questions, but I do really want to invite the audience to participate. This is a town hall meeting, so if please raise your hand, don't be shy, and I'll start us off. So one of the things that has been, I would say, concerning and also very, in a way, frustrating for me doing my work here in Baltimore, and I see that you in North Carolina may be experiencing the same thing, is that when I'm in the clinic, I feel that the majority of the patients that I see, unfortunately, being diagnosed when they come into the hospital, the Latino patients coming into the hospital, symptomatic with a seizure, they have toxo, they have TB, and so they're quite sick, and this is how they enter care. And we started seeing this, as soon as I started getting into this work several years ago, and we thought that we could really address this in a very easy way by getting some low-hanging fruit. So at that moment, at that time, the Baltimore City Health Department didn't have an outreach program that was culturally competent in the sense that there was no one that did outreach in Spanish. And so we were able to get that started, and Alejandra can talk a little bit more about how she did that with others, got the trust of the community, and they go out to the street and they do tons of testing in community-based organizations, in the streets, out in bars. And so we thought that by doing that, we would really turn the tide. But unfortunately, I'll have to say that although we've had some successes, 5 years later, we still, I would say that the majority of our patients still come in to the clinic very late and symptomatic. And so I think one of the difficulties has been reaching the really high-risk groups. And those high-risk groups can be, for example, men who have sex with men. We know that in the Latino community, that's a very common mode of transmission. We're not seeing it as much among our foreign-born patients. It could also be other high-risk groups that are just hidden and hard to get to. And so the question is how to do that. So my first question, I'm going to pose it to the group, and anyone can take it out. Let's address the issue of men who have sex with men. So we know that if you look at national statistics, 70% of the transmission among Latinos is among men who have sex with men. But in our clinic, and from what Anne has presented, also in North Carolina, among foreign-born Latinos, that proportion is smaller. The question that I have is whether that is because the transmission among Latino immigrants is just different, the dynamics and the type of transmission is different. That's one possibility. The other possibility is that our services and our testing is just not reaching that group. And the reason we're not seeing that is because we're just not diagnosing them and they're not coming into care. And so I was curious to ask the panel what you guys think about that question. So anyone want to take that on?
Well, I'll take that on and get you guys thinking, getting ready. I'll tell you just by working a few different roles, what I have seen a lot of times is a little bit of denial as far as who you're having sex with, per se. When we hear like men having sex with men, usually what I hear from Latino men is like, well, I'm having sex with a gay man. It's not like we're gay or I'm bisexual. It's like I had sex with a gay man, or other words they use in Spanish, which are not always so attractive. So I think the stigma of saying, well, I had sex with a man is something that people want to keep under their belt. I don't think they always disclose honestly to their social workers, to their doctors. It's my opinion on that. And HIV is for gay men. So although they might be having sex with men, I'm not gay, so that means I'm not going to get it. And I think that also has to do with sexual practices, as far as who is penetrating, who's being penetrated. So I think that has a lot to do with how people think transmission happens.
Alejandra, can you tell us a little bit about what your experience has been when you go out and do outreach on the street and you talk to people about these issues?
Yes, it's kind of like, it's very similar than what Alfredo is saying. When we talk to men about their sexual preferences, most of the time they say that they are heterosexual. It's very difficult to get them to admit that they're having sex with another man, but we really know that it is really happening because we do a street outreach, we talk with other people, so we know that the men that identify themselves as heterosexual sometimes get sex from other men, like in bars or like in on the street, or but they never will disclose it to us as openly. It's very difficult, yeah. And it's understandable because of the discrimination that already is not just for HIV, but gays in the Latino community are very attacked, and there is a lot of violence against them. So I think it's kind of understandable that they're like hiding that kind of behavior.
So I think you both brought up the issue of stigma and discrimination, which applies perhaps not only to men who have sex with men, but also to HIV. And I would potentially add another layer, which is that a lot of the people that we serve are also undocumented. So there's the socio-political discrimination that comes from that status. And I wonder, Suzanne, if you could comment on how you think that sort of structural situation impacts both HIV risk as well as the likelihood that people are going to access HIV services.
So one of the things that we've been looking at in Baltimore is with the day laborers in particular, who most of them are undocumented based on where we're picking them up for research studies, not picking them up, but many of them, as Alejandra said, are very vulnerable. They're here without documentation mostly. They're in threat of being attacked, and there's not a lot of statistics that really attest to this, but from their perception, they're targeted by African Americans of low economic status because they're known to carry cash. They get paid in cash. They're also very vulnerable in the sense that many of their employers hire them on the street corner and then don't pay them, or pay them much less than they originally said that they were going to be given, and so on. And so we see a great deal of distress. And this distress, some of the ways we commonly see it enacted, to kind of coping skills, one may be pure release, and so you're going to the bar, you're drinking alcohol, and this is very well known in immigration studies that this is a very common practice for, there's not a lot of social activities, and so the social activities end up in a bar, a lot of men, and then often some women serving drinks at a very expensive price that may or may not then later involve sex, or men then going off with other men, or transgendered Latinos. And then also one of the things that is very, very not well understood is the transactional sex that occurs with men by men on these street corners. So when we did focus groups with 59 men and asked them about these occurrences and how often they happen, and over a third had been approached by another man, by someone who wanted to pick them up for a job, and then they end up saying, once they're in private, the job is to have sex. And so there's a lot of issues in terms of sexuality and how you kind of deal with engaging in same-sex behaviors beyond orientation, which is more of a methodological and theoretical kind of position that we can explore later if anyone's interested. But in thinking about the risk here is that you have population that is extremely vulnerable, who really cannot go to the police, who cannot go to or don't feel that they can go to a worker center and fight for their rights. And so if someone offers you $30 for a 15-minute engagement, that's a lot of money. And it may be more than they're willing, they're able to get if they take, a so-called, regular street corner job. And so, I think there's a lot of different issues that need to be addressed, but this vulnerability piece, the structural piece is extremely important, and the way that kind of impacts their ideas of masculinity. And again, just to kind of think about what it means, think about a man standing on a street corner. It's very much like prostitution, right? You're sitting on a street corner trying to sell yourself for work, maybe not ideally for sex, but but you're still standing on a street corner, and that can be very demasculating. And then two, if you can't find a job, which means you're not going to be able to provide for your family, that's very demasculating. And so it can enable individuals to do things that they wouldn't otherwise do. And then, of course, if you can think about the role of stigma that Alejandra and Alfredo have talked about, you know, it's just very difficult to think about engaging these people into care, talking about these issues, which unfortunately we know are happening. But they're going to be the hardest to really engage and to talk about these issues.
Thank you. I don't know if anyone wanted to follow those comments with any questions, and if not, I'll continue.
Hi, I'm Donna, and I work with both documented and undocumented Latinos in psychiatry. And so one of the things that I find since coming here from Denver is how my role as a mental health provider is almost, sometimes I think I'm one of the first people they tell. I'm like their confessor. And so a lot of times they're just so ashamed, and it's not, some of the men who I've dealt with in the past have said exactly what you're saying. It was like, and I find that the treatment for alcohol and the loneliness is lacking, very much so. But also one of the very interesting things that's come up lately is that the pool of people from whom you can choose is very different than in your country of origin. And so people make trades with, deals with themselves. And I think that's an aspect that I think I'd like to explore more of, and I think it actually could really help with figuring out how is this transaction going on. That's just my little aside. But,
Great.
and I thank you very much for all that you're doing, because I find that a lot of the men actually have families, and they're spreading the wealth, and the idea of condom use, that's another thing, making condom use a very sexy thing, would be something very important, I think, to help still, kind of quell the tide that I fear is coming on because of my knowledge of what is happening, both in the bedroom and on the street corner and in the bars, etc. Thank you, and thank you for your work.
Yeah, and just
Thank you,
quickly,
Donna.
I want to mention about the condoms. So when these men, these 59 men that we talked to, when they talked about HIV risk, it was never within the context of having sex with another man through these transactional encounters, or even in the bars if they're, whatever. And I also acknowledge that some men might be having sex with men because they purely want to. I just want to say that because I know sometimes people think like, oh, there is actual desire, and that certainly happens. But the men that we talk to don't perceive this transactional sex as being a risk. I mean, when they talk about what is their risk of HIV, it's having sex with a female sex worker. And so, again, if you can think about ideas of sex, and where they're on the street corner in this case, they're probably not carrying condoms. And so, again, we get into these logisticals of prevention that are both, mental education as well as structural barriers that can increase risk of transmission. And then, again, on this note, and I don't want to speak forever because I can, but one of the things that Dr. Page and I have spent a lot of time talking about is the fact that right now among Latinos there's not a huge prevalence of HIV in our population here, but we see the potential within this network for there to be just an influx. And because you have so many sex partners within this semi-closed network, it could spread rapidly. And so we see on these street corners an in, because a lot of these individuals who are hiring these men for sex are not Latinos. Some of them are, but a lot of them are African Americans or white or anything else. And we know that Baltimore has such a major problem with HIV, and so it's a great, unfortunately, it's a great way to get HIV really within the community that then can just spread very quickly. So it's a dire need to address.
Yeah, so is another question up there, and then I'll probably follow up with a comment over there. Yes, go ahead. there's another question. Sorry. Let's take turns. Yeah. Go ahead.
Oh, good afternoon. Thanks so much for being here. My name is Agatha. I actually work with an organization in Southeast Baltimore where there is a growing Latino population, and I work in a neighborhood where there are some, like say, long-term, Mexican immigrants who've been here for many, many years, and a lot of newly arrived Central American immigrants. I guess my question really is focused for the panel on kind of what your experience has been in terms of looking at a more family-centered approach to HIV prevention or treatment, for that matter. I mean, because I know I heard a lot of talk about like individual men seeking, sex, but what about like a person, a husband or a wife who's, potentially at risk, or maybe already, is HIV positive? How has the family been affected, or how has the family kind of used as a part of the approach to treatment or prevention?
I want to address that, if I may.
Yes.
Just through the years, because there's somebody in the room who kind of triggers a memory. The reality is there's not much funding for that. So a lot of times it's done because wonderful people in the community who are concerned about public health and keeping our community healthy take out time out of their jobs in the day to do a presentation about HIV prevention, about how to use a condom properly, and have conversations that they may not feel comfortable having with their sex partners, and specifically addressing women, single or married or somewhere there in between. There's a real concern. I always feel like, I guess I'm a mama's boy, so I always feel you keep your mother healthy, everybody in the house is going to be healthy, because they're going to have real conversations. They're going to continue taking care of their children, their spouse, their loved one. So I really wish we would address that more. Right now, it appears that we try to be a catchment for everybody, and again, if we're talking about public health, a lot of times we'd be very specific in who we're reaching out to and how we're reaching out to them. And right now, I think that's not the case. Again, lack of funding, that's not a blame game, it's just what it is. But so right now, it's more like a general approach. Who's in front of you? And you have to know how to make that, the caveats that come behind that conversation of, if I'm speaking to a 20-year-old gay young man who's just coming out sexually, to a 35-year-old woman with her second husband possibly and 3 children, it's a totally different conversation.
So I think, you bring up a very important point. We see a lot of the women that come to our clinics, as Anne described also in North Carolina, are coming through pregnancy, and many of them are coming here to meet a husband, and often that's how they get infected. So that's one way that we end up getting the family involved. And then something that Alfredo has not mentioned is that he actually runs a very successful HIV Latino outreach program, which I think has really made very impressive strides in terms of really integrating HIV care and talking about it into the family. And this is one of the things that has not been mentioned, is that disclosure of HIV status among this community is actually very, very low because of the stigma that was mentioned before. And so that's one place where people can safely discuss their status and have really been able to bring in their family members. I'm going to ask one more question from the audience, and then I do have another question that has been bugging me for Anne, so I'm just going to have to put it in there. But please, go ahead.
My name's Andrew. I'm with the AIRS housing group, and I thank the panel again. I'm familiar with some of you and have provided. I much appreciate your work. To echo and emphasize what Agatha is saying, I was wondering, I wrote this as our cultural exploitation of accessing care misplaced, in the sense of we work in an individual access model. If we give you the impetus of why you should go, you should go. We work with Alejandra and Alfredo Santiago and some of the folks from Hopkins. It became clear to me that why people are accessing care, or what's their motivation to be healthy, can be fundamentally different culture to culture. And then I want to pick up another part about the low-hanging fruit piece, to question whether or not the low-hanging fruit, is it really the fruit, or is it a branch, because we don't see it to be that. And I'm thinking about MSM stuff, and is MSM a very white kind of iteration of what we're doing in public health? We think about folks with PL, but when I think about Latino and Hispanic culture, there's sometimes a tripartite discussion about exchange reconsider that. And all this is overshadowed women again. And we keep kind of bringing this up on that.
So who wants to take a couple questions, but who?
Yeah, no, I think that point is fantastic. And, speaking about MSM and categorization, it's something that I know, coming from an anthropological perspective, think about a lot, because, there is this challenge that we do, to a certain extent, have to make boxes. And it's an unfortunate, reality, because the world does not exist in boxes. And these boxes are all connected. And I think it's one thing that has been really challenging. And you see successes like with the categorization of the down low, but then all of a sudden it became about the download, and all these people who didn't fit into this category got excluded. And you can see MSM, which was, really started as a way to move against homosexuality, because not everyone. And so, it's something that I think we constantly come up against, and we think we find some sort of solution, however, well or not well it works, and then we constantly are faced with these challenges. And I think one that hasn't been well addressed is among the Latino population, or among groups in Central South America, because we know that there's a lot of fluidity in sexuality. Matthew Gutman has done amazing work in Mexico looking at this, and it's not necessarily seen as the sexuality we see it in the United States, and I think it's something that we don't give a lot of attention to when we're looking at HIV within this community. I don't have an answer, but I think it's really important that we continue that dialogue, and I think it's fantastic that that came to your mind, because it's something we don't talk about, particularly in schools of medicine and public health, where we operate by, and we've done, and I'm not saying there's something wrong with that, it's just, it's how we move forward, but that gets lost sometimes, and it's really important not to let that get lost.
Alejandra, do you want to make any comment about the issue of culturally how people access care, and whether we should be taking that into account a little bit more, and what your experiences has been as you have developed this outreach program?
Yeah, I think sometimes with our community, it's very difficult to get them to get any kind of care until they're very sick, mainly because there's such a much need of make money, like they need to work, and people keep postponing going to the doctor. And HIV testing, let alone that, sometimes, for example, we are in the van, we're in a corner, and people is going to work. They really don't want to lose 5 or 10 minutes of their time getting tested, because they need to get to their jobs and then care for the kids. I think the priority, the health, is one of the least of their priorities, and that's why you see they seek the help when they're very, very sick. Also, it's there's not a lot of places where they can go to the doctor because they don't have documents. Well, the people that we work with, and so it's difficult to access. And the time that they get the care, sometimes it's late.
And I think you've mentioned in the past fear of getting tested.
Yes, definitely. Well, the specifically HIV care, yes, is fear of death, fear of discrimination, fear of what am I going to do if I know that I am positive? Am I going to where am I going to go for care? Then we explain, yes, you can have care, but then it's how am I going to explain to my family? I mean, there is a lot of stuff that comes. Also, the fear of getting kicked out of their houses, because sometimes, especially men that are single, they come here and they live in a house with other 4 or 5 men, right? Unrelated, they're not family. So if somebody in the house finds out that they're positive, there's a lot of discrimination. Sometimes we know of patients that have been kicked out of the house. They think that the roommates think that they're going to be infected through a bed bug and stuff like that, because there's a lot of lack of education. So the easiest thing to do is just try to ignore the problem and not knowing it, so they don't have to deal with another thing in their lives.
So maybe I'll ask one question to Anne, which was brought up by Donna and Suzanne, and this is, I think, some of what you're trying to get to with your phylogenetic analysis, which is the question of networks. So I often get asked this question: where do you think these immigrants got infected? Did they get infected in Baltimore? Was it in transit in the Guatemala-Mexico border, Mexico-Guatemala, or somewhere along the way? And the data you should sort of suggest that at least right now there's no obvious clustering that you've been identified in able to identify in North Carolina. The caveat I would say is that all that data is from people who are diagnosed. And so we know from the late presentation that we're seeing sort of the tip of the iceberg. Until, without having a real representation of who's infected, it's really hard to know, whether indeed transmission is not happening in Carolina or North Carolina, or if it's happening somewhere else. And the other added complexity, which I think would be critical to understand in terms of thinking of prevention and interventions, is how much mixing is there with networks, and Suzanne also alluded to this. So far, from what we've done, we get the sense that there's a lot of Latino, among Latino sort of intra-ethnic sexual practices, and that of course can impact the risk. But we're starting to see some of that influx potentially from other groups, and I think as the young people who are being born here grow up in the US and are American, that's going to change even more. So any thoughts on that?
Yeah, those are great questions, and we wish we could answer all those and with molecular methods. That would be really nice. But yeah, it's hard to say where people get infected, and especially if people are living with the virus for a long time, you can have a certain amount of divergence. Reconstructing the transmission cluster, obviously it's going to be very, difficult. Whether, onward transmission happens after that, or participation in further transmission chains is also possible. We do, from our kind of molecular epidemiology, phylogenetic work, did see, a fair number of the patients being involved in these networks that we do consider to be local in North Carolina. So there is a certain amount of transmission happening among the Latino groups. And it does look like there is some within ethnicity, transmission. It's hard to tease it out because it does look like there's definitely onward transmission that's probably heterosexual. There is transmission among MSM groups. We have clusters that are all men. The majority do report having sex with men in the past. Occasionally, for a couple instances, we do some of the Latino men involved in those clusters did not report having sex with men, identified as heterosexual, but were involved in a cluster. We have a few instances of that. It's not the overwhelming majority. It's hard to really, say if there's much of a, down-low phenomenon, because it really does look like that there is a mixture between heterosexual transmission and discrete MSM groups. And we do see some of that within our phylogenetic data.
So I didn't know, do we have time for more questions? We don't have time for more questions in this setting, but hopefully you will all join us for lunch, and then you can attack our panelists and ask all the questions you want, as well as the food. I want to thank you all. I guess I'm going to give you each the opportunity, you don't have to take it, to say, very succinctly, like 2 or 3 words, a challenge or opportunity that you see in this work among Latinos. So why don't we start with 1 or 2 words, Alfredo. What is the biggest challenge or opportunity you see in terms of addressing HIV among Latinos?
She says 1 or 2 words because I'm long-winded. So with that, don't judge. I mean, when you talk to somebody, when you're doing an intervention, the thing is like not to judge, right? Not to be shocked, like what? Because when you
That's more than 1 or 2 words. Don't judge. Alejandra?
Just 1 word, right?
Yes.
Just try to understand the person and all the challenges that they're having. It's different, like from the people that is here as immigrant is totally different as the people that you are used to see that have a social
All right.
security, etc.
So don't judge, understand. Suzanne?
No, I would just say that I think that this is a really important opportunity, a really great opportunity to prevent a major outbreak among the population if we take it. And it's hard sometimes to get on that prevention side and not wait until the problem exists. But this is a fantastic opportunity.
All right.
So.
So don't judge, understand, prevent.
Yeah, and going along with the prevention, I think one of the biggest challenges and one big initiative that we have is really finding ways that we can reach people for early testing. And
Reach.
Reach.
And with that, we're done.